This movie is meant to be an example of various techniques which are done in manual therapy in manipulation or thrust techniques. None of the tests for determining the suitability of these techniques will be demonstrated, but at the very least, none of these techniques should be done without establishing, for example in the cranial area, the integrity of the transverse ligament, the alar ligament, and the integrity of the vertebro-basilar system. Having said that, we will demonstrate purely techniques of manipulation, starting with the craniovertebral area, looking at C0, C1. The standard technique in manual therapy for this area will be a distractive manipulation, which can be done in supine lying or in a modified position of side lying. The technique consists of the following: gaining contact of C0 by obtaining a contact behind the mastoid process, a slight side flexion with the congruent rotation of the skull. The line of the pull is through the occiput on the right side in the example given, and the manipulation is a little thrust at the barrier of movement. This can be done in side lying. I'll invite the patient to come to the end here with your arm over the end. This position, which is the same position of the head with slight side flexion, slight opposite rotation done simultaneously to maintain the axis in its middle position, allows the thrust to be slightly more from the posterior aspect, which enables the head to go into a slight flexion position on the application of the impulse, which is felt to take it into a more safe range. Side flexion of the C0, C1 is usually obtained more efficiently by mobilization. In this case, side flexion to the left is lost, which means that the atlas gives the impression of moving to the right instead of moving to the left. The technique would be to side flex the head to the side flexion barrier, obtain contact on the right side of the atlas to allow the head to go into its congruent rotation as the technique is performed, and then the impulse is applied through both the occiput with stabilization of the atlas, or holding the occiput and moving the atlas in the correct direction. It is imperative that the chin is not stopped from moving into the rotated position. This technique can also be done in the sitting position as a manipulation. The standard technique demonstrates a full rotation of the skull, largely obtained at the atlantoaxial joint, with contact on the atlas with the stabilizing hand, the manipulating hand and body work in concert to pull the occiput into slight forward rotation on the left hand side, while at the same time achieving side flexion to the left. A technique will be demonstrated in that way. It is felt in manual therapy that the full rotation of the skull is inadvisable, and that fixation of the atlas can take place in the neutral position for the atlantoaxial joint, and that the technique can just as efficiently be achieved at that range there. To go down to the atlantoaxial joint, this joint allows flexion, extension, and rotation, and the rotation is an extremely large movement, so the joint tends to become dysfunctional, probably into hypermobility. It's very important not to overforce the rotation movement. Therefore, distraction is the key technique. In this case, the atlas is engaged, the head is rotated to give slight side flexion rotation to allow the axis to stay in the middle position, and the thrust is applied under the atlas on the right-hand side in that fashion. Rotation is possibly permissible if in the testing of rotation dysfunction, it is felt that the rotational dysfunction is on the forward gliding left facet. If it's on the backward gliding right facet, manipulation other than distraction would not be countenanced. To obtain rotation at the AA joint on the left-hand side to regain the forward gliding facet movement, the cervical spine from C2 down to C7 would be taken into full side flexion to the left. This would rotate the spine into rotation left, locking out any tendency for the cervical spine to move right. At the same time, this has taken the atlantoaxial joint into right rotation to the end of its extreme of movement. Therefore, the technique of rotation can be a small impulse applied at that range to reobtain the forward gliding of the left forward moving facet. This can also be modified by the side lying position seen previously, where the head would be side flexed to the right in the presence of rotation to the left, engaging the contact point at the back of the atlas, applying the impulse in a slightly postero-cephalic fashion, which would tend to take the head into a slight flexion position, avoiding any tendency to go into extension, which is felt in this area might put some stress on the vertebral artery system. In view of the posterior moving facet being stiff, it is felt in manual therapy that this is much more advisably taken into extension by mobilizing. This is demonstrated as follows. You sit. Limitation to the right has been ascertained, and this has been linked with limitation of extension, signifying the inadequacy of backward movement of the right moving facet. This is obtained by applying a side flexion technique to the left, which goes with rotation to the right, stabilizing the axis, making sure that the forward moving facet is stabilized, and by going through the body we get an extension plus rotation to the right of the right backward moving facet. This is a very useful technique and much safer than trying to manipulate this joint into extension. Mobilizing flexion of the atlantoaxial joint has been modified somewhat over the years so that the anterior arch of the atlas is retained against the dens and not pulled forward in a gross, although local, flexion movement. So some contact is made by the anterior arch of atlas being held against the dens and the head being taken into the flex position. The posterior arch of axis is engaged with the supporting hand. The mobilizing hand is placed over the posterior arch of the atlas. The contact on the head retains the anterior arch of atlas against the dens, and the head can then be mobilized into flexion. This can be augmented by eye movements. It can be augmented by post-isometric relaxation techniques of active muscle relaxation. And these are felt to be more efficient ways of obtaining flexion at the atlantoaxial joint than doing thrust techniques. A number of techniques will be demonstrated for the cervical spine in lying. First of all will be the distraction technique, which will look very similar in many aspects to the way that distraction was applied to the craniovertebral area. Contact is made with the upper bone of the segment being mobilized. The neck is then taken into flexion to obtain some ligamentous locking of the low part of the neck below the caudal bone of the segment. The segment in question is taken into the neutral position, and then locking is obtained from above downwards by using a non-congruent position in slight flexion or in neutral of side flexion to the right in the presence of rotation to the left. In this position, two possibilities exist. One is to do a distraction thrust. The other possibility is to obtain a glide movement. Both of those are characteristic of manual therapy manipulation. The distractive movement engages the barrier and the impulse is applied. Whereas with the glide will be applied in line parallel to the zygapophyseal joints, and the angle is usually obtained by taking the point of contact and directing it towards the opposite eye, which gives the correct angle for each of the facet joints. So going down to the C4, 5, flex from below upwards, go into the neutral position for the 4, 5, lock down to 4 by rotation side flexion, and then glide towards the opposite eye. These techniques of forward gliding can be obtained in a slight increase of lordosis. The hand is placed, the rotation to be obtained will be, in this case, right rotation, and the right rotation will be obtained by producing a forward gliding movement on the left-hand side. The facet joint in question, which will be 3, 4 in this case, contact is made under 3, which is lifted slightly to increase its lordosis. The barrier then is engaged from above in the same way as previously by side flexing, in this case to the left with rotation to the right. And the technique then will be achieved by doing a little flick in the direction of the left facet joint coming up through the eye on the right-hand side. So the barrier is engaged and the flick is obtained by doing a small motion in that direction. These all obtain a forward gliding movement. It is possible to obtain an extension motion. In this case, the facet joint of 3, 4 will be taken down into an extended position, still using an upper lock of side flexion, which gives us the tendency for the immobile facet to go into the extended position. This is going into a close pack, and so care must be taken not to over manipulate this, otherwise the joints impact strongly. The technique will be to take the joint into a side flexion rotation And then instead of doing the technique demonstrated previously, which was to bring the contact up here, the contact will now go downwards in line with the lower facet. So the technique will be engage the barrier and then impulse down to reobtain an extension motion. That can be slightly varied to obtain more movement of tilt at the uncovertebral joints. This will be done on the right-hand side of the neck. In terms of segmental immobility, this is tested into side flexion to the right, which is found to be immobile. This is then analyzed by looking at rotation and looking at the side tilt motion. If the side tilt motion appears to be more difficult than the rotational facet-based motion, then a slight tilting movement of the uncovertebral joints should be obtained. This is by taking the neck down into a side flexion movement, and instead of the modification of pushing in that direction which reobtained extension, the technique will be more in this direction to obtain a side tilt, looking like that movement there. In view of the distraction motions reobtaining movement, in the case of a joint that has stiffness, there is always the chance that if we have a hypermobile joint below the level of stiffness, that the glide or the distraction may put too much strain on this already excessively moving joint. So if we take the example of C3-4 being stiff and C4-5 being hypermobile, pulling 3 away from 4 might pull 4-5 into a greater degree of movement. What would be an efficacious idea would be to hold 3 in a stable position and push 4 in a caudal direction into 5, thereby closing 4-5 and not applying any stress to it. This can be achieved in the following fashion. The example will be of 3-4 being stiff, 4-5 being hypermobile, and 4 will be moved away from 3. The neck would be side flexed to the left, rotated to the right, which would hold 3 in a cephalic posterior position. The superior facet of the lower bone of the segment, which is 4, will be engaged, and then a pure gapping movement of 4 against 3 will be achieved by pushing in a ventral caudal direction, as demonstrated there. This can also be done in sitting, where the head can be taken into a side flexion to the left, rotation to the right, which is brought the C3 arch into a cranial dorsal direction. The C4 will be engaged, its superior facet, against the outside edge of the index finger, and the pure gapping of the facet joint can be achieved by pushing in a caudal ventral direction. This can also be done from the same side, same contact. If this is more comfortable, just engaging on the C4 posterior arch and pushing caudal and ventral in that direction. Lay back on the back here. Okay, we'll stop there for time, Dave.
Nice job.
The normal locking procedure that has been shown up until now is to manipulate on the right side, to side flex to the right in the presence of rotation to the left, which is the non-congruent lock. The problem with this procedure sometimes is that the arch that is being engaged of a particular vertebra becomes a little less prominent, so that it is possible to use the reverse of this, still using the non-congruent lock, by taking the head into left side flexion. Right rotation makes the arch of the particular vertebra upper segment more prominent. By holding that position, the manipulation can then be achieved by a little distraction motion. The same position can be used in side lying, which alters the direction slightly of the distracting thrust. Can you turn and face that way? Yeah. In this particular case, the side flexion once again is done to the left in the presence of rotation to the right. This might have particular value in attempting to manipulate the C7, which becomes very indistinct in the position of side bend to the same side, rotation opposite. The technique would appear in the following: side flexion to the left, rotation to the right, engage the arch, and then a manipulative thrust can be applied in that position. Occasionally, one of the features of manipulating has been not to manipulate in the presence of a weak nerve root. Traction is usually the method that is used, either mechanical or manual, for such an eventuality. However, under certain circumstances, when this has been tried and no effect has been gained, perhaps a joint block is stopping the effect of the distraction at the discal joint. Under these circumstances, it is permissible to apply a distractive manipulation. However, the joint must be held distracted and the impulse applied to this distraction. So in the classical technique, assuming C5, C6, or C6, C7, the upper bone of the segment is engaged. The classical position of side bend rotation opposite is used. A traction is applied to the joint, and superimposed on this traction is a little releasing impulse. In all the techniques that have been shown, the distraction is on the side of the thrust. There is one technique used in manual therapy where the release is gained on the opposite side. This is a technique where the classical position is still used, and then instead of going in a distractive direction or a glide direction on the side of impulse, the thrust is placed at right angles to the neck, which increases the side flexion to the right, gapping the left side joint. This might have some value if a patient is held in this position and they cannot be got into a side flexion towards that side to effect a release in the classical manner. The technique is done in exactly the same way as before, of side flexion to the right with rotation to the left. But the thrust now, instead of the traditional manner of distraction or glide, is placed at right angles across the line of the joint. It is not recommended that this technique is used as a primary procedure, only if it has been impossible to release the joint in any other way. Manipulation of the lumbar spine is commonly an effective procedure. Within the context of manual therapy, the reasons for doing a manipulation have been clearly defined. And certainly the existence of neurology, the existence of myelopathy coming from a higher level would be contraindications for this procedure. Within the treatment protocol, also, if any of the positions are held as an experimental starting position and cause an increase in the peripheral pain, this would also be considered to be a contraindication for the technique. A standard basic position is utilized, which uses non-congruent locking positions. From below up to the affected segment, a ligamentous lock using flexion is used in the classical position. Flexion is taken up to the joint to be manipulated and then slightly eased off to leave it in its neutral position. From above downwards, a rotation is applied, rotating down to but not including the affected joint. This position is then fine-tuned by bringing the patient into a more vertical position of the bed for the therapist's convenience, not allowing the change between the orientation of the upper lever and the lower lever to occur during this procedure, and then fine-tuning is applied to allow the movement to move into the affected joint. In this particular position, a variety of possibilities exist. This segment